Well, thanks for the invitation to give this talk, and I particularly want to thank Rafaela for the title given to me of my talk. What on earth is undifferentiated autoinflammation? Well, let's see. So I think we face some challenges when considering autoinflammation in general, and the punchline really is that undifferentiated autoinflammation is when you have no idea what you're treating. And I guess that's a fair enough title for me because that applies to virtually all the patients that are sent to me. But the good news is that we have new tools to help with diagnosis, genomics, and also functional assays. And I'll present to you, based on the past 15 years, a very simple framework that I've applied at least to stratify your patients, and end with a few conclusions. Okay, so when I came into this business, there were only 4 genetic diseases available and 1 non-genetic disease. And if you didn't have any one of those diseases, you would have unclassified inflammation, undifferentiated autoinflammation, whatever you want to call it. And it was very clear to me that those 4 diseases, genetic diseases, were just the tip of the iceberg, and I spent most of my time under the surface of the water having no clue what I was treating, and applying various clinical labels like Behçet's disease, familial Behçet's disease, polyarthritis nodosa Castleman's disease, and all these old-fashioned things that we use much less commonly these days. So there's many new diseases, interferonopathies, DADA2, inflammasomopathies, and many others waiting to be discovered. But it's even more complicated than that, because you might think, well, monogenic disease, 1 gene, find the gene, you've made the diagnosis, targeted treatment, game over. The fact of the matter is that up to 5% of patients with a genetic diagnosis have another genetic diagnosis and a blending of phenotypes. And therefore, is this a concern in autoinflammation? Well, here is a baby that presented to us, and he, from birth, came out with a C-reactive protein of 300, a swollen and red arm, a completely distended abdomen, and vasculitic lesions on his legs. And it took us a long time, but he was bleeding from his gut, platelets were in the boots, platelet count of 9, to work out that he had 2 genetic diagnoses, the Wiskott-Aldrich syndrome and also familial Mediterranean fever. And there are other examples of Candle syndrome where you have diagenic models of disease. So it's a bit more complicated than one gene, one disease. Okay, so we face a number of clinical challenges. There are many tens of emerging autoinflammatory diseases. I heard a number this morning, 42. I think that's a gross underestimate because there are many other diseases that we don't traditionally think of as autoinflammatory but can present with autoinflammation. These have overlapping phenotypes, and I think this is the most important thing that I want you to take home. These phenotypes overlap much more than you ever read in any textbook. And all this business, all these tables you see about heads and the number of days of fever, differentiate from TRAPS, I'll propose that it's a lot of rubbish. Okay, and that these diseases overlap much more, and you as a doctor have no clue. Okay, they may be monogenic, diagenic, allogenic, complex, and there are mimics. There are things out there waiting to trip you up. Fabry disease presenting with cerebral vasculitis that looks like Behçet's, for instance. So other groups of disease, including metabolic storage diseases with a previously unappreciated autoinflammatory component. And all of these technologies that you're going to be hearing about at this meeting can definitely help, but they're mainly tools. So you as clinicians are not out of a job, because at the end of every pipeline is a human being to interpret and synthesize all of this and make the best for your patient. Okay, so I have 30 minutes for a new patient in my clinic and 15 minutes for a follow-up. So you need, and I'm a very simple man. I like that thing today about men having immature neutrophils. That's definitely me. So ask yourself the first question, is it even an inflammatory condition? Many times fevers are reported, but may not be true fevers, maybe other manifestations, so just bear that in mind. If so, if you have established it is truly inflammatory, is the immune system underactive, overactive, or a bit of both more than likely? So if you come to the conclusion that, yeah, I think there's really inflammation going on here, don't forget that many of the diseases that we as rheumatologists look after, autoinflammatory diseases, are now overlapping with proper immune deficiencies. In other words, there may be an underactive immune system with immune dysregulation driving autoinflammation. And just because you call your clinic an autoinflammation clinic doesn't mean to say that your patients are going to come with autoinflammation. Do not forget that they may have autoimmunity, they may have lupus, they may have JDM. The one that always messes people up is Takaysu arteritis, where all you might get is a bit of weight loss and a C-reactive protein of 30 and an ESR of 60 and nothing else, unless you think about Takayasu and do an MRI MRA of the aorta, looking at, for large vessel vasculitis, you will not make the diagnosis. There may indeed be truly autoinflammatory disease. We've heard of the many tens of those diseases, but increasingly there may be patients with immune deficiency whose first presentation is with autoinflammation and new diseases that span all three. So this nice clear boundary about monogenic and autoinflammation versus autoimmunity, it overlaps much more than you will feel comfortable with. All right, so what are the technologies that are helping us solve all these clinical challenges? Definitely next generation genetic sequencing. Think about your patients, sequence early, and then think again. And many functional assays, but the problem is that the functional assays are tailing behind the advances in genomic technologies. The result is you'll get lots of variants of uncertain significance, and you have absolutely no idea if that's the cause or is even a problem for your patient or not, unless you've got access to functional assays that can begin to probe that. So some examples: targeted gene panel sequencing, that's what we like. We have designed a panel that not only rules in diagnoses but rules out important mimics. Whole exome sequencing, but again, that can send you down many blind pathways because you find lots of variants of uncertain significance. But if you've got good pipelines, and the important point is that new softwares that allow linking of phenotype to genotype, such as Exomizer, can really streamline this process. In the UK, within 5 years, we will be only doing whole genome sequencing on the back of the 100,000 Genome Project, but with targeted scrutiny of panels of genes within the whole genome. It's very cheap to do that now. What functional assays do you use? Well, many already exist: complement, perforin, granular release assays for the HLH spectrum. Enzyme activity, ADA2, important new enzyme, but actually there's only one centre in the UK that does it. That's our centre. I know of Duke in the US that does it, so these are tests that are important but not widely available. You can measure peripheral blood cytokines, you can do RNA gene expression, look at the interferon score, for instance. We spend a lot of time talking about that today. And then other downstream assays that are available, but perhaps more on a research and not fully integrated into routine clinical care. It's now possible to measure attomolar concentrations of interferons. So to give you an idea what an attomole is, if you take a teaspoonful of sugar and put it into an Olympic swimming pool and wait 1 million years, you can still detect it. Caspase-1 and ASPEC formation to probe inflammasomes if you get a variant of uncertain significance in the NLRP3 gene, for instance. And many others, largely aspirational in routine clinical care, but they do exist. Okay. The point I'm making is that these all exist, but really your job as the clinician is provide a clinical context and make sense of all of this for your patients. But despite all these challenges, it is actually quite simple to stratify your patients. And here's how I do it. Okay, so you've got suspected autoinflammation. Let's see if this button works. Yeah, there we go. You've definitely confirmed that it is autoinflammation. It's not fabricated or induced illness and reported fevers. It's true, you think. You do your sequencing and at the same time might begin about some functional readouts. The ones to start doing early, if you think it's in the HLH spectrum, are perforin, granular release, because these are diseases that can kill patients. But there's diagnostic synergy between the two, so I don't see necessarily that it's one or the other. You need both. But then, quite quickly and simply, you can begin to therapeutically stratify. So IL-1 blockade, if you had absolutely no clue what you're dealing with, you may consider calling it atypical systemic GIA, get funding and use anakinra. And these are the diseases, the inflammasomopathies. And as crude as that sounds, I'll show you some data that might support that such a blind approach. Definitely for DADA2, it's TNF blockade, so you can take that one disease and stratify that. And you saw Amanda Umbrello's data from this morning. Then you've got the prospect of using JAK inhibitors to begin to block specific interferon if you think you've got a type 1 interferonopathy. And I think you will be hearing the really big game changer in HLH is the monoclonal antibody against gamma interferon, emapalumab. It's going to be transformative for that disease and is worthy of its own stratification. But remember that all of these targeted and clever treatments may fail, and that if your patient is not working and not getting better, you may have to consider other more drastic approaches, allogeneic hematopoietic stem cell transplantation. And in the future, you're going to be hearing much more about gene therapy for autoinflammation. Okay, Let's think about IL-1 blockade for undifferentiated. So here's some data from our unit. It was published this year. So we took 22 children and we provided a pragmatic definition. What did we mean by undifferentiated autoinflammation? Well, it was those patients who were in a bit of trouble with inflammation, who did not have CAPS, FMF, MKD traps, PFAPA or systemic GIA. What endpoints did we apply retrospectively? Physician global assessment, i.e. did I think they got better or not? CRP and serum amyloid A. And when you apply that crude metric, I can say that 72 responded well to anakinra, 36 achieved a full clinical and serological remission within 3 months, but that 28% had absolutely no response to anakinra and clearly needed something else. These were serious diseases. 3 out of 22 died, and 1 needed a bone marrow transplant, so that it was not a trivial disease that we were treating in this cohort of patients on the whole. Data 2, deficiency of adenosine deaminase 2. Here's a patient with slightly low neutrophils and this terrible skin. You can see that on the top of the thigh there's been some skin grafting for a large lesion and multiple ulcers, but actually a CRP and an ESR which were relatively normal. Another patient represented at the age of 15, but when he was 3 had had a stroke and then was lost to follow-up, then presents with some cutaneous nodules on the soles of his feet and a ischemic digit, and actually had a wasting of his hypothenar eminence. And when we biopsied one of his nerves, the sural nerve, you can see necrotizing vasculitis, and this was the first patient that we had picked up deficiency of adenosine type 2. So the main features are recurrent fevers, livido-racemosa, polyarthritis nodosa type phenotype, ischemic strokes, lacunar in their description, sometimes intracranial hemorrhage, immune deficiency, bone marrow failure, and virtually any organ can be affected. Okay, it turns out that there's a very good and targeted treatment for this condition. Not quite sure what adenosine deaminase 2 does. It definitely is an adenosine deaminase, but probably exerts an important role in the maturation of the immune system. And when you're deficient in it, you get the skewing towards a more pro-inflammatory M1 macrophages that produce a whole host of pro-inflammatory cytokines. But of the 3 that I've listed here, TNF-alpha seems to be by far the most important. Here's one of the cases. This is a boy who already had 1 leg amputated for an ulcer like this on the other side. Was heavily colonized by staph and osteomyelitis, but we gave him antibiotics and adalimumab, and you can see the ulcer healing in these pictures. So the point is there has never been a formal clinical trial of anti-TNF. Therefore, it's really hard in some countries, including my own, to get your government to pay for it. And when you try and propose a clinical trial, the patients with Data 2 who are very organised tell us it would be unethical to do a trial that did not involve anti-TNF. Yeah? So we're in a situation a bit like FMF. Colchicine was so effective that actually there's no way we're going to do a trial, and yet the regulators want us to do a trial to get the evidence to be able to treat the patients. So it's a problem for us, and it's not a solved problem as yet. So anti-TNF is definitely good for the autoinflammation and the vasculitis, probably not for the marrow failure, and possibly not for the immune deficiency. Allo-HSCT is going to be a very good approach. There's over 25 cases now done, but there's some caveats. Because this is a disease that can present with full-blown strokes, marrow failure and immune deficiency, or you can have the same genotype, absent enzyme activity, and have absolutely no symptoms. Be careful about choosing a sibling as a donor for that BMT, because there have been 2 documented cases where that was exactly done because the child was well, the donor gave the bone marrow, but by the way, they had the same disease, and the disease just came back and they needed a top-up. So always screen all family members when you're considering that approach. What we're currently working on, and happy to say that we're having a collaboration with NIH, is an approach using gene therapy. So it is possible in vitro to fully correct using a self-inactivating lentivirus. And we promised the patients last November when we were in Washington that within 7 years the first patients will be coming through to clinical trials. Let's see if we can do that. Okay, so the other approach that Amanda Umbrello has explored is giving plasma. And if you do that, you can see that the half-life of the plasma, which contains ADA2, is a bit short, really, to be useful. But what she did show is that if you have 733 patient months before anti-TNF, you got 37 strokes and absolutely none on anti-TNF. There have been anecdotally some cases of stroke whilst on anti-TNF. It may be that after a while you can develop anti-chimeric antibodies and neutralizing antibodies, and you may have to change. But this raises a really important point. If you are what we call pre-symptomatic for DADA2, in other words, have absolutely no features but have the genotype and the enzyme activity, should you start treating that patient with anti-TNF? What the patients have told me, if they're completely well, they'd rather not do that. They'd rather save the medicine for when they need it, for fear of using it for years, developing a resistance to it, and then when they really need it, there is nothing. So there's still quite a lot to sort through here about all of this. And then just when you were getting comfortable enters the interferonopathies, and there's millions of diseases. And I was dismayed to be invited to talk about recommendations for interferonopathy because it's complicated. Every molecule here that's involved in the production of type 1 interferons can be mutated and can cause a type 1 interferonopathy. Okay, so here's the first savvy patient that we diagnosed posthumously 3 years after he had died. You can see the vasculitis of his ear, the sort of lupus-like face, the peripheral vasculitis, and what killed him was the interstitial lung disease, a really prominent feature of the sting-associated vasculitis with onset in infancy. This is the Candle syndrome. This is the very typical annular and violaceous rash with resolution. And this was one of two siblings who had a diagenic form of the disease caused by one mutation in PSMB4, one in PSMB9, i.e. not the classic PSMB8. But there are about 40 or 50 genes within the proteasome pathway, and so there's likely to be many, many causes of Candle-Praz syndrome. And later on in that disease, this unusual pattern of lipodystrophy, where you see bits of lumps under the skin and this intra-abdominal fat accumulation and a stripping of fat from the face in some patients. And the Aicardi-Goutieres syndrome, the one that I have least experience with as a pediatric rheumatologist, that presents with really catastrophic and early onset progressive brain disease, usually always with intracerebral calcification. In one genetic form, there are 7 genetic forms of this at the moment, can be associated with a vascular occlusion and a moya-moya type phenotype. And then, of course, these are very neurologically damaged children, and there are various arthropathies that can develop in a Charcot type pattern. And one of the biomarkers that's been useful has been this interferon-stimulated gene. So you look at RNA signatures within the peripheral blood, and lo and behold, you can see many genes downstream of type 1 interferons that can give you a clue to the diagnosis. There are a number of treatments, but I'll summarize it by saying the only treatments that we're considering in our recommendations are steroids and jakinibs. They're the only two treatments. Some folks have begun to look at reverse transcriptase inhibitors for Aicardi-Goutieres syndrome. These can improve your biomarkers, but have not yet demonstrated any clinical improvement and therefore remain experimental. That's the work of Yannick Crow. So steroid and jakinibs. So one of the medicines is called baricitinib, and some work that we had taken part in with Raphael and others at NIH. 18 patients, 10 with Candle, 4 with Savvy, and 4 other. In other words, no confirmed genetic diagnosis, but an interferon signature and in a bit of trouble. Therefore came into a compassionate use trial. Baricitinib for 3 years. Symptom scores decreased, so the patients felt better. Prednisolone was weaned, and they had better growth. They had some infections, gastroenteritis and opportunistic virus infection, BK, viuria and viremia. And my patient who was involved in that trial, one of them died with BK viremia as part of the feature. This is the data from Yannick Crow's group published this year or just last year in the New England Journal of Medicine. So the idea is that we are comprised genetically of lots of ancient retroviruses, and some forms of Aicardi-Goutieres syndrome, it's if you're putting too much DNA and intracellular accumulation of DNA, you might be able to reduce the DNA load by giving reverse transcriptase inhibitors, and there's a very good animal model. And if you do that to actual patients, some of the interferon scores can improve, but there has been no demonstration that these make any clinical improvement, particularly of the neurological phenotype. So watch this space, and at the moment, this approach cannot be routinely recommended. Okay, so before I hand you over to Fatima, who's going to give you some real-life cases, armed with all this knowledge to solve for her, I'll leave with the conclusion that next-generation genetic sequencing combined with emerging functional assays have significant diagnostic impact for those patients you have no clue what the cause of the autoinflammation is. The overall advances in genomics have outpaced advances in functional assays, so we have to play catch-up to help us understand the genetic findings. that human reporting of genetic findings remains the final step in any NGS pathway, and the final genetic report is profoundly influenced by the clinical phenotype that's provided. So please remember that when you're requesting your genetic tests. In my country, there is a complete disconnect between diagnostics. Our government funded the 100,000 Genomes Project, but when we find these clever diagnoses, we'll not fund even medium-cost medicines to treat them. So there's a disconnect, and we have to, as a group, get that sorted. And I've given you an example of 3 broad therapeutic stratifications: IL-1 blockade, anti-TNF, and JAK inhibitors. But there are going to be other treatments for sure in the future. I'll stop there. Thank you.